Please welcome Associate Professor Kathy Wu.
Thank you very much, Lydia, for the introduction, and hello, everyone. I'm going to share my screen. Bear with me. Show caption, share screen. Okay, hopefully you should be able to see my slides.
Excellent, thank you.
Okay, perfect. So today I'm going to focus on familial ovarian cancer. So I'm going to talk to you about, it's a very, very dense talk. So apologies in advance. I'll do my best to make it interesting. So I'll talk to you about what familial cancer syndrome is, when to suspect that, and when to refer your patient to a familial cancer clinic. I'll give an overview of some of the ovarian cancer genetic syndromes, and I'll give you some recent advances in genetic testing from both technology-wise and cost perspective. And I'll talk about why genetic testing is important from your personal patient management perspective, as well as from their familial perspective. And I'll talk about some risk management options and screening for those at an increased genetic risk. And then there will be psychosocial implications associated with genetic testing, which I'll touch upon as well. And finally, if time allows, I would like to talk to you about other advances in genetics that may be relevant to your patients in general practice, such as pharmacogenomics. Okay, so a bit of background. We know that cancer is common in the general population. The majority of cancers occur as a result of somatic mutations that occur later in life in a cell that that is lost in a cell that then leads to downstream mutations, and eventually the cells grow out of control and turn into cancer. So these somatic mutations, they are confined within the cancer cells and they cannot be passed down to the next generation. However, in rare families, they develop cancer as a result of a genetic predisposition due to a germline mutation that they are born with. And these germline mutations can be passed down from one generation to the next. And I'll use the next slide, a diagram to illustrate the difference between somatic and germline mutations further. But to put things into perspective for you, for any epithelial ovarian cancer, we know that, so it's actually not rare, and we know that up to 15% of these epithelial ovarian cancers can be caused by a BRCA1 or 2 mutation. About 2% can be caused by Lynch syndrome. Under 1% can be caused by other rarer cancer genetic syndromes. And I'll be giving you an overview of these genetic syndromes in the later part of my talk. So I'm going to tell you the difference between germline and somatic mutations again. So germline mutation is usually inherited from a parent. So in this case, it's inherited from the father through the sperm, and the asterisk just denotes a mutation. And because the mutation is present in first ever cell of the embryo, and therefore it gets copied down into all subsequent body cells of this individual, including this person's germ cells. And therefore a germline mutation can be passed down from one generation to the next. On the other hand, a somatic mutation, as I said before, occurs later in life in a particular cell that can be triggered by environmental factors such as radiation or lifestyle factors, and that then leads to downstream further mutations that occur within that particular cell line. And therefore, somatic mutations are confined within a certain cell line that turns into cancer, and therefore somatic mutations not usually involving the germline, and therefore somatic mutations cannot be passed down to the next generation. Okay, so it's important to know that not everyone with a germline mutation will go on to develop cancer, and this is when the Nielsen-Toohey hypothesis comes in. So if I use BRCA1 gene as an example, as with most of our other genes, it comes in pairs because one copy we get from mom, the other copy we get from dad. So in a normal cell, we'll have 2 healthy copies of the BRCA1 gene. But if a person carries a fault in one of these gene pair, that person has inherited the germline predisposition. However, they don't develop cancer until later in life when a second copy of that gene is mutated or hit. And that can be caused by environmental factors again, or other genetic factors. And this is when cancer develops. So I've given you a good example of why genetics does not equal heritability, and that applies to most cancers because, again, they are caused by so many mutations that cannot be passed down to the next generation. And another reason why genetics does not equal heritability is that a lot of the common conditions, including most cancers, they occur as a result of polygenic etiology. So for polygenic etiology to manifest symptoms, it's dependent upon the interplay between environmental factors and genetic factors. And of these genetic factors, each of them plays a really, really small effect. They are genes of minor effect. One alone is not enough to give you the predisposition, but if you have the right combination of the genes of minor effect together with the right environmental triggers, then you can develop symptoms. So if I plot to go further, if I plot the currently known ovarian cancer genes on this graph, so x-axis being the relative cancer risk, and sorry, that's y-axis, and x-axis being minor allele frequency. So anything below 5% is considered to be rare. So we know that I've mentioned about BRCA1. So these are the Angelina Jolie genes you would have heard of or come across. So these are high-risk genes, and they are rare. And there will be a few more moderate risk genes, such as the Lynch syndrome genes, the BRIP1, PARB2, RAD51C, and RAD51D. And these are still rare. And there will be a lot of the common low-risk variants or SNPs that the number of which continue to increase because they continue to be identified. So each of these, again, is not enough to cause ovarian cancer, but if you have the right aggregation with the right environmental factors, you can develop certain cancers. And so these are what we call polygenic risk alleles, and current diagnostic genetic testing on a clinical basis is not able to pick it up. They don't follow Mendelian inheritance, and therefore is not strongly heritable. Unlike the high risk and moderate risk genes, they follow Mendelian inheritance. Most of them are dominantly inherited. So that means that a person who has the gene mutation will be at a 50% chance of passing it down to each of their children. So these are the genes where clinical testing is available. So let's keep going. So when do we suspect familial cancer? So we look for clues such as early age of diagnosis for that particular cancer, and other clues such as having multiple affected relatives on the same side of the family. So we assess maternal, paternal sides of family history separately, unless they're consanguineous. And also we usually see affected relatives across multiple generations. Or if we see multiple primaries in one person, which can be synchronous bilateral breast cancer or metachronous, they develop breast cancer and later develop ovarian cancer, for example. Or if we come across typical pathology, such as high-grade serous ovarian cancer, then we should be thinking about BRCA genes. And also we look for associated or related cancers within a family. For example, if we see ovarian cancer and breast cancer coexisting in one family, then we'll be thinking about the BRCA genes. Or if we see ovarian cancer with bowel cancer and endometrial cancer in one family, then we'll be thinking about Lynch syndrome. And I'll talk about this in more detail a bit later. So you can see why family history is important. So I've borrowed this case from a problem-based learning case of a medical school that I teach. Amelia, who is 25 and well, has come to see you because her mom was recently diagnosed with breast cancer at 62. So you would know that, and there's no other affected family members on the mom's side of the family. So you would know that having a first-degree relative diagnosed with breast cancer over 50 years of age would not significantly increase Amelia's risk. However, you will also know that it's important to assess the family history on the other side of the family. So you dig further. And Amelia tells you that although her father is well, but she has a paternal aunt with ovarian cancer at 58. And this aunt had a daughter who had bilateral breast cancer and died at 42. Amelia's paternal grandmother developed breast cancer at 54 and then later went on to develop ovarian cancer at 60. And a great aunt had breast cancer at 40. So this is a strong family history with 4 affected relatives across different generations, some with early onset cancer and also multiple primary cancers. So this family history would suggest an autosomal dominant predisposition to breast ovarian cancer, such as one caused by BRCA1 or gene or 2 mutations. Okay, so let's keep going, and I'll be coming back to this case in a minute. So when we come across a family history like this, what kind of tools do we use to assess the risk based on family history? So you would know about iPrevent, which is endorsed by IACGP, and that has superseded the Freiburg assessment tool that some of you may be familiar with. So iPrevent is a validated tool that will give you a breast cancer risk assessment based on a person's personal and family history. So another tool that we use is CanRisk. So CanRisk, again, is a validated tool developed by University of Cambridge, and it not only predicts the breast cancer risk, but also ovarian cancer risk, as well as the likelihood of carrying a pathogenic variant in one of these breast ovarian cancer genes. By taking into account of the personal, hormonal, family history, and also genetic testing results that may have happened in a family. It's predominantly used by familial cancer clinics, but I believe it is an open tool. Anybody can access that, and we use that to determine eligibility criteria for publicly funded genetic testing, and also to guide clinical screening, especially if genetic testing comes back uninformative. So these are some screenshots of taken from the CanRisk. So this is where you can input the genetic testing results in the family. And then after the input, then it outputs these graph that the lifetime, so it outputs a lifetime risk of breast ovarian cancer over a lifetime and plot it against the population risk. Okay, so when do we refer a patient to a familial cancer clinic? So the basic rule is that we can use either the breast cancer criteria or ovarian cancer criteria. So as I mentioned before, if we have one first-degree relative with breast cancer over 50, that person will still be at or slightly above the population risk. If you have one breast cancer diagnosed under 50 in the family, or if you have 2 breast cancers, regardless of age or diagnosis, then that person will fall into the moderate risk category. And when we have 2 breast cancers plus any of the following high-risk features as listed in this open box here, then that person will fall into the potentially high-risk category, and they should be referred to a familial cancer clinic for consideration of genetic testing. So what are these high-risk features. So if there's additional breast cancers or any ovarian cancer in the family, if anyone with multiple primary in one person, any breast cancer diagnosed under 50, or if there's Jewish ancestry because of the 3 founder mutations in BRCA1 and 2 genes, or if there's any male breast cancers in the family, pancreatic cancer, or high-grade or metastatic prostate cancer. Or if we use ovarian cancer, sorry, I need to move the screen so I can see. If we use ovarian cancer criteria, if we have anyone with high-grade non-mucinous epithelial ovarian fallopian tube or primary peritoneal cancer at any age, then they should be referred, or if there's other unusual tumor pathology that I'll show you in a minute. Or yet another criteria is that if there is already a mutation known in the family, then of course they should be referred. So I'm going to introduce AVQ at this stage. Some of you may already know. So this is essentially a national guideline that is regularly reviewed and updated, and that contains guidelines for referral, when to refer to a familial cancer clinic, and also guidelines on genetic testing and risk management. So this is a screenshot of the referral guideline based on the breast cancer criteria. I'm not going to go into detail. You can go to the website to have a look. And this is the guideline for referral based on ovarian cancer criteria. So these are so as I mentioned before, high-grade non-mucinous epithelial cancer or ovarian cancer that is mismatch, MMR protein or mismatch repair protein deficient, which is a marker for Lynch syndrome. Or if there are rare tumor pathology, such as ones listed here, such as small cell carcinoma of the ovaries, hypercalcemic type, then they should also be referred. Or if there's family history of bowel cancer or endometrial cancer diagnosed under 50, together with ovarian cancer, then they should also be referred. Again, this is all on the AVQ website. So what do we do at the familial cancer clinic? We usually like to verify the family cancer history, especially the ovarian cancers, by tracking down the death certificate if needed. And then we determine the most likely cancer genetic syndrome that we're dealing with is. We can individualize the cancer risk assessment using CanRisk. And based on that, we can also determine whether somebody is eligible for publicly funded genetic testing if any of the validated prediction to shows a probability of 10% or greater. If they are not eligible, there's also the option for self-funded testing as well. And of course, we talk about all the implications associated with genetic testing to the patient themselves, and also the implications for the wider family as well. And we do predictive genetic testing if a mutation is already known in the family, and we make risk management recommendations based on the AVQ guideline. So this is the familial cancer clinic locator, where you can find your local familial cancer or any local genetics clinic, actually. So it's divided into general genetics, cancer genetics. And this is housed at the New South Wales Health Centre for Genetics Education website. Or alternatively, you can also find a list of the clinics from the HGSA website, Human Genetics Society of Australasia website as well. Okay, so I'm going to use the next few slides to give you an overview of some ovarian cancer genetic syndromes. So the most common one is probably BRCA1 and 2 related breast ovarian cancer syndrome, affect 1 in 400 Australian people, but is a lot more common, 1 in 40 in those with Jewish ancestry because of the founder mutation that I mentioned. It's dominantly inherited. And the BRCA genes are actually tumor protection genes, the tumor suppressor genes involved in the repair of DNA double-strand breaks. If there is a mutation or a change in either BRCA1 or 2 gene, then there is increased predisposition to female breast cancer, high-grade serous ovarian cancer, prostate cancer, male breast cancer, and pancreatic cancer. So this is the lifetime tumor risk is summarized in ABQ under risk management guideline for female carriers of BRCA1 or BRCA2 mutations, BRCA1 and BRCA2, and compare with the general population risk. And this is the lifetime risk of cancers for male mutation carriers, again, taken from ABQ. Okay, then I'm going to go on to talk about Lynch syndrome. So it's previously known as hereditary non-polyposis colon cancer, but we don't use that term anymore because we know the cancers can affect beyond the bowel. It's relatively common, affects up to 1 in 300 people, and it's dominantly inherited, caused by a mutation in one of the MMR genes. And if there is a mutation, then it leads to increased risk of a variety of the cancers and tumors. So we suspect Lynch syndrome if the family history meets Amsterdam 1 or 2 criteria, or if there is MMR deficient tumors. So what's the Amsterdam criteria? So this is Amsterdam 1 was the original criteria that was revised to reflect the extracolonic cancers that can occur in people with Lynch syndrome. So essentially, it's a 3-2-1-0 rule. So if you have a family history where there are 3 affected family members with a Lynch syndrome related cancer across 2 generations with at least 1 family member diagnosed under 50 years of age. And then also 0 means after excluding familial adenomatous polyposis, which usually leads to hundreds of polyps that can be detected usually on colonoscopy. So if we see this family history, then we should be thinking about Lynch syndrome and refer the patient to the familial cancer clinic. Or another criteria we use would be tumor testing. So nowadays, we routinely do tumor testing for the mismatch repair proteins by immunohistochemistry for any incident bowel cancers or endometrial cancers and ovarian cancers. And microsatellite instability MSI testing is can also be done as well, and it's a marker for MMR deficiency, essentially. So if there's any loss of staining in 1 or 2 MMR proteins, and that would suggest Lynch syndrome, but it's not diagnostic. The diagnosis will still require genetic testing. And I thought I would point this out because we have come across, and I'm sure you may have come across as well, that you have an elderly patient who's got a single sebaceous adenoma that you have excised and sent for histopathology, and they've done MMR immunohistochemistry and show the abnormal staining pattern. Usually on the pathology report, it will say, suggestive of Lynch syndrome, and then you'll be wondering, should I refer this patient or not? So, so this is taken from ABQ guideline as well. So if you come across that, if there's no personal or family history of Lynch syndrome related tumors, then they don't generally need to be referred or to have genetic testing. Okay, so this is lifetime risk of cancers associated with Lynch syndrome, summarizing ABQ under risk management guideline, and you can see that it's divided into gene-specific risks because each of them will have different penetrance. So penetrance meaning that the chance of you developing cancers or symptoms if you have inherited the genetic fault. You can see that the penetrance for PMS2 gene mutation is generally reduced. Okay, so what are the, so I've shown you this table of the rare ovarian tumors, and they should be referred, and this is because ovarian sex cord tumors with annular tubules can be associated with Peutz-Jeghers syndrome that can cause other types of cancers and tumors, such as hematomatous polyps and epithelial malignancies, especially if you see this characteristic hyperpigmentation on the lips and inside the oral mucosa, then the alarm bell should be ringing. Okay, so if you come across small cell carcinoma of the ovary, hypercalcemic type, that again should be referred because it's associated with the SMARCA4 gene. So this is based on 3 independent groups publishing similar findings in Nature Genetics in the same issue of Nature Genetics. If you come across ovarian Sertoli cell tumor, that tumor is associated with DICER1, and again, they should be referred. Okay, so I'm going to take the next couple of slides to take you through very briefly along the, the genetic testing advancement pathway over the last century or so, how far we have come and where we are up to. So I'm gonna start with the technology side of things. We have been using Sanger sequencing for a long time, over a century. So essentially, it can only sequence one gene at a time. Therefore, it can be labor intensive, time consuming. However, it still remains the gold standard. But increasingly, since the early 2010s, next generation sequencing has become more widely used. So its ability to massively parallel sequence multiple genes at the same time. And that then led to the availability of gene panel testing, testing for a panel of the relevant genes for a particular condition. And then since the turn of the century, since early 2020, we have moved into the genomic era of using whole exome, whole genome sequencing. So we have the ability to sequence the entire coding or non-coding regions of the genome. So although it is becoming more widely used, but it is still predominantly used for general genetic conditions in the pediatric population. For cancer genetic conditions, we're still predominantly using gene panel testing. In terms of the cost of testing, the cost continues to drop every year. Previously, we have had to spend a couple of $1,000s to sequence one gene, but currently we can get a gene panel done of 1,000 genes or so to be under 600 Australian dollars. And also this increasing number of the NBS rebate item numbers for genetic testing, which I'll talk about in a minute. So this graph hopefully may give you a better idea. So the cost of sequencing one human genome 20 years ago in 2001 was $1 million, and it has exponentially been reducing to today. To sequence one human genome would cost, just under 1,000 Australian dollars. Okay, so the cancer gene panel, the advantage is that it would allow us to investigate multiple cancer genetic syndromes being considered in your differential diagnosis. For example, if you have breast cancer, ovarian cancer, bowel cancer, then you could think about testing for the Lynch syndrome genes as well as breast ovarian cancer genes. And these are some of the genes that may be included in ovarian cancer gene panel. And as I mentioned before, there's an increasing number of NBS item numbers. So this is a screenshot of the NBS item number for a breast and ovarian cancer gene panel. So why is genetic testing important? So let's first look at the personal perspective, that it can guide personal management, including cancer management. For example, a young woman with newly diagnosed breast cancer, if she was found to carry a BRCA mutation, then she may elect to have double mastectomy instead of breast conserving surgery, because her chance of developing contralateral breast cancer is significantly increased. And another reason is to guide eligibility for PARP inhibitor, which is a targeted treatment that I'll talk about in a minute. And also there's implication for risk management of the other associated cancers. If they survive breast cancer, nowadays the survival is pretty good for breast cancer, then we need to manage their ovarian cancer risk and vice versa. And also, if we know what the causative variant in the family is, then there will be family planning options available for those who carry the genetic mutation, including pre-implantation genetic diagnosis. So we go through IVF, and then we biopsy the embryos, and we transfer back the unaffected embryos for the pregnancy to continue. Okay, so there will also be familial implications. So if we know what the genetic cause is in the family, then it can open up the option of predictive genetic testing for the unaffected relatives to see which ones need intensified screening or risk management, and it can also spare those ones who are testing negative for the familial mutation. They don't need the unnecessary screening. And of course, reproductive option will also be available to the wider family if they carry the mutation. So I mentioned about PARP inhibitors. So what is PARP? It is poly-ADP ribose polymerase. It's an enzyme that recognizes DNA damage and facilitates DNA repair. So PARP inhibitors is a medication that can inhibit DNA repair pathways and therefore cause death of the cancer cells, especially in BRCA deficient cells, or those cells that are deficient in homologous recombination, which most cancer cells would be. So this diagram is taken from a publication there. So essentially, in a normal cell, we have both, remember BRCA is a cancer protection gene, so is PARP1 pathway. So in a normal cell, we have both pathways working properly, and therefore, if accidentally there is an error being made during, regeneration, our cells continue to die, through our life and regenerate, and that process, there may be error made in that process, but as long as these checkpoint pathways are working properly, then there is repair and cell survival. If you look at panel B and C, if one pathway is working properly, but the other pathway is not, then as long as one is working, then again, there is repair. But panel D shows that on the most right-hand side, shows that if you, in somebody with BRCA mutations, so the BRCA pathway is not working properly, if you give them PARP inhibitor to inhibit the other pathway, and then there is no repair, and therefore it leads to cell death of the cancer cells. So that's how it works. So It's a very busy slide, but essentially in the US, there are 3 PARP inhibitors that have been FDA approved, predominantly as maintenance therapy for patients with ovarian cancer after they have responded to platinum-based chemotherapy. But recent research has shown that PARP inhibitor can be beneficial for newly diagnosed ovarian cancer as well, especially those with a BRCA mutation, or if the tumors show deficiency in homologous recombination. And therefore, in Australia, we have 2 PARP inhibitors that are TGA approved and PBS listed for various different indications, but as of 1st of January of this year, the PBS indication for one of the PARP inhibitors, olaparib, was extended to include those with newly diagnosed ovarian cancer, whose cancer shows HRD deficiency as monotherapy. So coming back to why genetic testing is important. So we have shown that it would have implications for cancer management, but also it will have implications for ongoing risk management. So this is taken from ABQ guideline, the most recent guideline, and bearing in mind is regularly reviewed and updated, and therefore these may be outdated in a few years' time. So essentially, the risk management options will include, for breast cancer, will include surveillance, usually from age 30 years of age, or earlier from 25 if there is excessively young onset breast cancers, but that can be individualized, based on family history and based on their risk trajectory as predicted by iPrevent or CanRisk. And we would usually start with breast MRI on an annual basis. We can also consider risk-reducing medications such as selective estrogen receptor modulators that I'll talk about in a minute. And the other option is to consider bilateral risk-reducing mastectomy, which has been shown to reduce breast cancer risk by at least 90%, and that is operator dependent. So it's important to know that the survival benefit associated with double mastectomy compared with surveillance has not yet been demonstrated. The optimal timing of risk-reducing mastectomy, again, should be individualized based on patient preference and risk trajectory. So tamoxifen, raloxifene, and some of the aromatase inhibitors have been shown to reduce the relative risk of breast cancer in high-risk women by up to 60%. So high risk is mainly based on family history, and to date, these clinical trials, they have not included sufficient women who are BRCA mutation carriers to reach statistical significance for primary prevention. However, there's a paper published a few years ago that showed benefit in reducing contralateral breast cancer risk for mutation carriers, and therefore some may have a role as secondary prevention in mutation carriers. But its role in primary prevention in mutation carriers is still unclear. And to bring to your attention that COSA has published a couple of the guides on medications to lower breast cancer risk, one for clinician and one for patient as well. And for ovarian cancer risk management, I need to emphasize that ovarian cancer surveillance is ineffective, so we don't use that for mutation carriers, but instead we recommend risk-reducing sublingual oophorectomy using this particular protocol because it's been shown that the protocol will involve careful examination of not only the ovaries, but also the resected tubes, because if there was evidence of STIC, which stands for tubal intraepithelial carcinoma found in that resected specimen, then these women are at a higher risk of subsequent peritoneal cancer compared with those who has no stage at the time of risk-reducing salpingo oophorectomy. We should recommend by 40 years of age for BRCA1 mutation carriers and by 45 for BRCA2 mutation carriers, but again, it can be individualized. It can significantly reduce the risk of ovarian fallopian tube cancers. And in the past, we believe that removing the ovaries would also reduce the breast cancer risk, but more recent research has shown that the evidence is inconsistent, and therefore we don't recommend doing RSO just as breast cancer prevention alone. Okay, so there will be other cancer risks associated with BRCA mutations, and therefore, again, this is taken from ABQ, but to manage pancreatic cancer risk, there is no evidence of survival benefit from surveillance, but if there is family history of pancreatic cancer, then surveillance can be considered. And for pancreatic cancer, it's recommended for male mutation BRCA2 mutation carriers from 40 years of age. And this is for Lynch syndrome risk management. This is taken from ABQ. As I mentioned before, there will be variable penetrance dependent on the gene, and therefore surveillance is also different depending on which gene it is involved. So I've shown you why genetic testing is important. So I'm going to talk to you about how we do genetic testing in a family. So we will usually take a blood sample, which is the easiest, but nowadays we can do a barcode swab, we can do a saliva sample, but usually from a living affected family member who was diagnosed as a relevant cancer at the youngest age in a family to increase the chance of finding something. And as I mentioned before, we are moving towards gene panel testing rather than single genes. And the process takes about 3 months, and it would cost the hospital $1,000 or the laboratory $1,000, and there's Medicare rebate if the patient is eligible. The results may be uninformative, and I'll explain what that means. So uninformative result means that when we don't find a mutation, and that happens in about 50% of the time for ovarian cancers. And why do we call that uninformative rather than negative? And that is because we are still limited by our technology and our knowledge as well. There may be a change that is undetectable by current technology, or there may be a change in a gene that we have not discovered. If we don't know what that gene is, we can't test for it today. So if we don't find anything, it could still be genetic. And therefore, we then recommend screening based on family. I shouldn't say screening, we recommend risk management for ovarian cancer based on family history. Okay, so what are some of the results? I mentioned that when we don't find a mutation, we call it uninformative. Another uninformative result would be that if we do find a variant, but the significance of that variant is currently uncertain. So all the labs will use an international classification criteria when they find a change using ACMG, and class 3 is uncertain significance. Essentially, that's another actionable result, just like and a negative result, essentially. But we usually tell our families that it can get upgraded to a causative variant, or it can get downgraded to a benign variant in the future as more evidence comes to light. So let's keep going. So if we do identify a mutation, then it opens up the option of predictive testing for the wider family. And that process is a lot shorter because we're only testing for one single variant rather than the entire gene or multiple genes. It takes up to 4 to 6 weeks time, and it's a lot cheaper, a couple of $100, and usually can be covered by Medicaid depending on what that gene is. Okay, so predictive testing is a lot more straightforward. We are just going to see whether they have inherited the familial variant. If they have, then we talk about risk management with them. Or if they have not, then that means they usually return back to population risk and they don't need the unnecessary screening. So coming back to these families, so now I think we can all agree that the paternal aunt is the best person to test because she's the only only living relative, and she was found to have a BRCA1 mutation. So now Amelia comes back to you to tell you this news and ask you what the next step would be. So one option is we can, and that would be the ideal option, is to test the immediate relatives first. So that would be Amelia's father, who would be at a 50% chance of having inherited this BRCA1 mutation from their late mother by inference. However, in real clinical practice, often we've come across men don't want to know, or they are not interested, or they are not, they've lost contact with the rest of the family, etc. So if that's the case, we can get around it, and we can bypass the dad and just go straight to the children. And in this scenario, we usually would counsel them that if they tested positive, then that will automatically declare their father's genetic status. Okay, I'm going to take the next few slides going through the some of the psychosocial implications of genetic testing. So I don't need to go through it. We've already touched upon the medical benefits. I'm not going to go through this again. But in terms of the psychosocial benefits, so we know that by doing genetic testing, we can remove the uncertainty about whether or not your patients are at risk or not. And it can help with family planning, life planning as well, career planning too. We can give more accurate risk assessment based on their genetic result. Then it's possible from their family history alone. And also we can spare those ones who don't need the unnecessary screening. However, there may be potential harms associated with genetic testing. We know that it can cause psychological stress. However, research has shown that the distress level will usually return back to baseline as time goes. There may be anxiety and guilt about the possibility of passing it down to their children or future children. And there would be stress associated with being the bearer of bad news in the family. Because if we do find something, and if that person is being tested, if that person is the first one being tested in the family and where a causative variant has been found, we will usually hand back the responsibility to that person to let the wider family know that something has been found and they may be at risk. And that may cause distress as well. It may also affect the family dynamics. For example, if we have 4 sisters coming forward for predictive testing and 3 of them tested positive, whereas 1 tested negative, then the 1 testing negative may feel being left out, not being part of the family, or may experience survival guilt, which is a well-established phenomenon in this setting. There may be concerns about possible effects on life insurance and employment. So what I'm going to talk about the insurance side of things. So it relates to risk-based insurance only. So life insurance income protection has nothing to do with health insurance, and usually would be relevant in a predictive genetic testing setting. So in the past, genetic test results may impact a person's ability to take out life insurance, but however, as of July 2019, there has been moratorium put in place that has subsequently been reviewed and extended indefinitely now from July of last year to put in effect that genetic testing results should not impact a person's ability to take out life insurance up to a certain limit. So that is where we are at currently. But currently, there are a lot of the discussions and a lot of the work from various groups to lobby the government to remove the cap. So hopefully that would happen in the near future. Okay. So I think this is my last slide, one of the last ones. So the take-home message is that most cancers are caused by somatic mutations, and these are not heritable. Germline mutations associated with hereditary cancers are rare, but it's important to identify this group because it will have personal implications, familial implications, and also and because it can allow risk management of the associated cancers. And there will be implications associated with genetic testing. And again, I just want to point out the useful resources for you, including the familial breast ovarian cancer chapter in the ISCGP Genomics in General Practice handbook, and also the ABQ referral risk management guideline, as well as the bottom website is the genetic service locator. So this is the Genomics in General Practice chapter on familial breast ovarian cancer. And if I may allow you to use, sorry, Lydia, I know you've come online. Can I use the last couple of minutes to quickly talk
Please
about
do.
pharmacogenomics? Thank you. Okay, so pharmacogenomics is about is based on that genetic factors can contribute to inter-individual variabilities in how we respond to medication. So these are the pharmacogenes, and they predominantly affect the cytokine P450 hepatic enzymes, metabolizing enzymes, and or drug receptor functions. It's a simple genetic test that can be done easily through a cheek swab, and that can cover more than 200 therapeutic medications that have been curated based on CPIC evidence. So if we take a patient group with the same diagnosis, given the same prescription, we know that a group of patients where the medication at a standard dose is going to be toxic because they are a non-metabolizer of that medication. Or yet another group of patients may not respond to that medication at all because they are a non-responder. And therefore, it's important to identify the right group of patients so we can give them the right medication at the right dose and at the right intervention window period as well. So we know that pharmacogenomics can potentially reduce adverse drug reactions to avoid therapeutic failure, increase medication tolerability, and indirectly medication adherence as well. There have been a few implementation initiatives happening in North America and Europe, but Australia, we are relatively lagging behind. Currently, only 2 pharmacogenetic tests are covered by Medicare. And we know that CPIC, which is Clinical Pharmacogenomics Implementation Consortium, has published quite a few clinical guidelines on specific drug-gene interactions to guide us how to alter the dosage based on the genetic results. And these guidelines cover a wide range of medications and including pain medications as well as psychotropic medications that may be relevant to your patients in general practice. So I would like to introduce the ALIGNed trial that I'm running out of the St. Vincent's Hospital and the George Institute for Global Health, that we are currently recruiting people with depression to see how pharmacogenomics can help us to find the right antidepressant for them. And please visit our website. And this is my last slide.
We have some questions in a Q&A box, and I'm happy to read it out for you. We might start with the sweet and short. Who can order genetic testing?
So I'm presuming it's referring to the cancer genes. So who can order? In the past, with our Medicare rebate, most patients would get referred to familial cancer clinic and utilize the clinic funded testing. But nowadays we have Medicare rebate. So increasingly, there will be other non-genetics professionals ordering this testing. So it's really and really we have another big area happening in genetics is that we try to mainstream some of the genetic testing into the hands of the non-genetics professionals, such as oncologists. For example, there's quite a few mainstreaming initiatives happening, I think, across most hospitals where for the gynecologist, especially for ovarian cancers, the oncologist or the gynecologist could order genetic testing, especially to guide their eligibility for PARP inhibitor. If they do find a germline mutation, then they can refer the patient to a familial cancer to discuss the implications, to discuss implications for the wider family, but also the personal implications in terms of the risk management of future cancers for that patient.
Thank you. Another question is an article in Australian Family Physician has suggested that all postmenopausal women be tested for CA125. My understanding is that this is not usually done.
All postmenopausal women be tested for CA125. I'm not aware of that. I'm sorry, I can't comment on that. So I'm a geneticist. So I deal with the diagnosis and management of high-risk women. So I can't really comment on the average women. But my very basic understanding is that there is no role for CA125 in women at average risk either. So yeah, that's my take.
Thank you. The next question is more of a small case. Paternal granddad prostate cancer, paternal grandmother AML, maternal granddad liver cancer, maternal grandmother pancreatic cancer. Should they be referred to cancer clinic?
Thank you for that
family.
question. So again, it's about pattern recognition. So prostate cancer and pancreatic cancer can potentially be related. AML is very non-specific, and liver cancer is usually environmental, so we don't take that into consideration. So essentially here, the handles will be prostate cancer, pancreatic cancer, and you're really going to come back down to the age of diagnosis. However, although they are related, but they are from different sides of the family. One is paternal and the other is maternal. So even though they are on two different sides, we can still independently assess the cancer or risk or probability of a germline mutation. It depends on the age of diagnosis.
Thank you.
If you're not sure, just refer to familial cancer clinic.
Thank you. Thank you. Next question is, who should we refer for patient with major depression?
Who should we refer
That will
for
be
patients
probably
with major depression? So, if you would like to, I'm presuming you're talking about pharmacogenomics testing. So there will be two major pathways. One is clinical testing. So clinical testing, again, it can happen. Well, I have to say that I'm one of the few who's familiar with pharmacogenomics testing within the genetics field. But I think I'm hoping that increasingly other genetic services will come on board. So you could potentially refer your patient for clinical testing to their local genetic service as a start. Whether they would be happy to fund testing, potentially patient may have to pay for testing themselves, or St. Vincent's Hospital, we've allowed some public funding available to fund patients, especially if it's being used to guide depression treatment. However, another pathway would be the research pathway, and this is why showing you the slide on aligned trial, we are trying to understand the jigsaw puzzle pieces that can, determine why some people respond to certain antidepressant but not the others. So not only looking at pharmacogenomics, but the aligned trial is also we are also collecting clinical data. We are collecting neuroimaging data because there's some research to show that subtle MRI changes can also predict antidepressant response. So we are trying to combine several data sets to develop a bedside prediction to better make that prediction. So the short answer to your question is, there are several pathways possible. But I also do know that some GP practices, they are familiar with ordering pharmacogenomics testing as well. So it really depends on your local expertise and whether you feel comfortable about it.
Thank you. We have another a small case of mother endometrial cancer found incidentally at hysterectomy from fibroids at 60. Daughter, first breast cancer at 45, second breast cancer at 50. Should they be tested for Lynch syndrome? Thank you.
So endometrial cancer at 60 and daughter first breast cancer 45, second breast cancer 50. I'm presuming it's not a second primary cancer. And given that breast cancer is not usually related to Lynch syndrome, I agree endometrial cancer should consider Lynch syndrome, but usually we would do mismatch repair immunohistochemistry on the endometrial cancer as the first line. If there is no loss of staining or if the staining pattern is normal, then we don't normally need to worry about genetic testing. Only if there is loss of staining in the endometrial cancer, then that person should be referred for consideration of Lynch syndrome genetic testing. And then daughter's breast cancer is a separate thing, depends on whether it's two primary cancers. If so, then should be referred, but if it's the same cancer. And the first cancer at what age again?
45.
The first cancer at age 45. Okay, then that would be that I would say should be referred because if there's other family history of breast cancer, usually, when I get to familial cancer clinic, we do a really comprehensive family history taking, and usually more family history comes to light. So if there's additional family history, then potentially testing should be done. But even if no additional family history, breast cancer under 50, that would put close relatives at moderate risk. And they should start screen. There's ABQ guideline for that, but you should probably refer them. Actually, you could do an eye prevent. You could do eye prevent in a clinic with them and take it from there.
Thank you. PARP inhibitors sound like a game changer in oncology. Have they been used in non-germline tumors?
So, yes. So they don't necessarily, maybe it's very complicated. And I have to say, because I don't deal with the management side of things, per se. I make recommendations based on the ABQ guideline, but there are different indications for different PARP inhibitors, and some of them you don't need to have a germline mutation. You can just have evidence of mutation, either BRCA mutations within the tumor, or evidence of homologous recombination deficiency within the tumor to have access to that.
Thank you. Next question, I'll try to read my best. Is tubal ligation protective for ovarian cancer in patients with breast cancer 1? Also, is salpictory indicated
Salpingectomy indicated in BRCA1, 2 as fallopian cancer is increasing these patients.
Thank you.
No worries at all. Yes, although we do know that tubal ligation can potentially is associated, I should say, with reduced ovarian cancer risk, but we don't use that as a risk management strategy. And in terms of the salpingectomy, so we do, yes, we do salpingectomy together with oophorectomy. So we do risk-reducing salpingo-oophorectomy for BRCA mutation carriers. And Excellent. That's in the ABQ guideline.